Hello, my name is Lynda Greenslade. I'm the lead nurse specialist practice in hepatology at the Royal Free. I'm just going to do a 15-minute bite-sized piece on Wilson's disease. Conflict of interest is Norgine an educational grant, nothing else. The introduction to the talk is just understanding what Wilson's disease is, how we diagnose it, how we treat it, and any issues in managing it. Wilson's disease was first described in 1912 by Kinnear Wilson, who noted progressive degeneration of lenticular nuclei with associated liver cirrhosis during a series of autopsies. It's fatal when overlooked, but curable when diagnosed. Wilson's disease is an inherited disorder in which defective biliary excretion of copper leads to its accumulation, particularly in liver and brain. It's an autosomal recessive disorder caused by mutations in the ATP7B gene coding for the ATP7B protein. ATP7B is a copper transporting transmembrane protein in which more than 500 disease-causing mutations have been identified. What's the role of copper? Well, our body requires 1 to 2 milligrams of copper per day in our dietary intake. It's mainly absorbed in the duodenum, and the copper-containing molecules bind with amino acids, polypeptides and albumin and are transported to the liver. Copper in the liver cells aids various enzyme processes, and excessive copper is excreted in the bile. Copper's job, about 50% of it is metabolized copper, is stored in the muscle and bone, with 15% in the liver and the rest in the brain, heart and kidneys. The liver is central to copper homeostasis, which is regulated by hepatocytes, mainly through biliary excretion or by binding the copper to ceruloplasmin. Copper is essential nutrient needed for mitochondrial respiration, melanin biosynthesis, dopamine metabolism, iron homeostasis, antioxidant defense, connective tissue formation, peptide mediation. Dietary copper intake is about 1 to 2 milligrams a day. It's difficult to be accurate, as copper in some foods depends on the copper in the soil and the method of food preparation. About 10% of ingested copper is absorbed in the upper intestine, and most of the rest of the ingested copper is absorbed by the liver. The ATP7B mediates excretion of excess copper into the bile and incorporation of copper into ceruloplasmin. When ATP7B is dysfunctional, ceruloplasmin formation and biliary excretion of copper stops. Accumulation of copper leads to symptomatic disease of the liver and the brain. It was previously thought to be rare, but estimates were based on adolescents or adults presenting with neurological symptoms. But new data suggests that these symptoms only occur in half of the patients with Wilson's disease, and that this is a disease of all age spectrums. In some populations, Jews from Uzbekistan and China, it seems more common. About 3 to 6% of patients transplanted for fulminant liver failure and 16% of young adults with chronic active hepatitis of unknown origin have Wilson's disease. And genetic screening for Wilson's is hampered by the range of mutations of the gene, particularly in these different populations. In one study, they looked at 215 patients and 46 had liver disease. The average age of presentation was 19 years, 8 months with liver disease and 24 years and 6 months with neurological disease. Studies remain ongoing and will be key in the future for successful genetic testing. It's also important to be developing international collaboration and to share data, and that's why a Wilson's disease register is been set up in Europe. How do our patients present? Clinical presentation can vary widely, but the key features are liver disease and cirrhosis and neuropsychiatric disturbances, with Kayser-Fleischer rings and acute episodes of hemolysis, often in acute liver failure. Clinical presentation can present at any age. The symptoms are very variable and not typical. Children generally present with liver disease. In older patients, neurological disease is often present. As the disease is now being recognized at an earlier stage, severe neurological disease and Kayser-Fleischer rings are seen less often. and often the disease progresses slowly. And in young children and adults, they're often referred for psychological testing for unruly behaviour at school. And this can often mean that Wilson's is missed, and it should be excluded in this group of patients. Acute hepatic Wilson's occurs in about 5% and 6 to 12% of all acute liver failure patients in adults. Affects 3 to 1, mainly females, query why, we don't know, and often onset is rapid with typical features of acute liver failure. Coagulopathy and hepatic encephalopathy, rapid onset, often with no neurological signs or Kaiser-Fleischer rings. They may also, with liver disease, present with acute fulminant liver, as we've just discussed, and it should be suspected in any young adult presenting with acute fulminant liver failure. Acute hepatitis or chronic liver disease, which in young patients often resembles chronic active hepatitis and autoimmune hepatitis, and Wilson should be ruled out. With neurological disease, they may present with different things such as a mild tremor, speech and writing problems, and these can often progress to dysarthria, dysphagia, apraxia, tremor, with rigidity syndrome like a juvenile Parkinsonian, and or with psychiatric presentation with depression, severe mood swings and psychosis. So how do we diagnose it? Well, the presence of the Kaiser-Fleischer rings are the key thing, but as we said earlier, we're actually detecting patients earlier. So we need to look for typical neurological symptoms that we described as previously, but also the low serum ceruloplasmin levels might help. However, low serum copper can be normal in half of all the patients and may be in the normal range. Free copper is less than 5% in normal patients, as the rest binds to ceruloplasmin and does not exceed 10. You can calculate free copper. If it's greater than 10, then a diagnosis of Wilson's may be made. This is a slide just showing the Kaiser-Fleischer ring, as you can see around the outside of the eye, and it's very typical. Diagnosis can also be made looking at urinary copper. Excretion is higher in patients with Wilson's disease, but in practice it can be difficult to collect, as many of the plastic pots have copper within their make of the plastic jugs and things. The hepatic copper content, which we can obtain via liver biopsy, is also increased in at least 80% of patients with Wilson's, and is less accurate though in neonates and young children. The treatment is oral penicillamine, which reduces copper bound to protein and so reduces the affinity of protein for copper. The copper is then excreted in the urine. As the levels fall, tissues begin to repair. Dose is 1 to 1.5 grams a day and is given with vitamin B6, which may become deficient. But one problem with penicillamine is toxicity and side effects, so patients need close monitoring. It's a lifelong treatment, and so compliance can be a big problem, particularly from young adults transitioning into adult services. Trientane is a newer drug which is mainly used more in America, with penicillamine being more favoured in Europe, and this enhances urinary copper excretion and is as effective as penicillamine and with less side effects. Zinc interferes with the intestinal absorption of copper, but there's less data around it, and it would only be used in combination therapy. So to conclude, Wilson's disease presents in many different ways. It can be missed. In acute liver failure, transplant is the only option. However, in patients with mainly neurological symptoms, transplant will not improve those symptoms for some of these patients, and they need careful discussion in the transplant MDT. Lifelong medication can reduce symptoms and reduce mortality, but mortality in this group over 20 years may still be as high as 20%. Issue of compliance is a big problem with lifelong medications and transition of children to adult services, as we mentioned previously. Thank you for listening. There is one thing to remember: it's fatal when overlooked, but curable when diagnosed. I think that's the important message to get across about Wilson's disease. There is a new thinkwilson.com website going to be launched in the next few months, where you can get more resources and information about Wilson's disease. It might be useful to look into that to see when it's available for us to look at, full stop. Thank you for listening. I will be doing a tiny quiz on the BLNA official webinar, and I'll be putting that up on the day when we recap the talk with you at that point. Thank you for your attention. Bye-bye.